Good morning to one and all. Today, we will be seeing a small presentation on history taking of ulcer. What is an ulcer? An ulcer is the break in the continuity of the epithelium of skin or mucosa, which is brought about by molecular destruction and it is covered by granulation tissue. There can be many etiological factors for an ulcer, like infection, irritation, deficiency, and other idiopathic reasons. The disease, due to a known or an unknown cause, and during this disease process, if the surface epithelium is breaking, it immediately forms an ulcer. Ulcer can occur in any part of the body, in the skin, or in mucosal surfaces like the oral mucosa, vaginal mucosa, etc. Each type of ulcer has a specific characteristic, and with the basis of this characteristic, we can go ahead and make the correct diagnosis and use the necessary treatment plan for reducing the ulcer. There is a certain methodology to follow to diagnose an ulcer. What is the duration of an ulcer? Any ulcer of duration less than a week is called an acute ulcer, and any ulcer which is having 10 to 14 days of duration or more than that is known as a chronic ulcer. What about mode of onset? Ulcers can develop after an injury or trauma due to a systemic or a local disease, following inflammation of a particular area in the body or an organ, following the development of vesicles on the surface of skin or mucosa. Coming to pain, some ulcers can be severely painful and some ulcers may be lesser painful, which can be found out on pain on palpation. Next is bleeding. Certain ulcers will bleed. For example, the ulcers that we seen in erythema multiforme. Coming to the clinical examination of an ulcer. When we talk about clinical examination, it is divided into two parts. One is inspection and the next is palpation. Inspection is everything which comes under inspection and only seeing the patient without using the hands. So under inspection, we have to notice the various characteristics of a particular dental anomaly, whether it is what is the number, what is the size, what is the extent, shape, where exactly anatomically is it located, how big it is, what are the surrounding factors, or how does it look. All of this has to be written down detail under inspection. So this is the basis of case history and clinical examination taking of the third years and the third years and the final year. Number one, under inspection, number of ulcers. Ulcers can be solitude ulcers or single ulcers or multiple ulcers. Under single ulcer, we have examples like traumatic ulcer, and under multiple ulcers, we have examples like herpes or anything like pemphigus, where multiple ulcers are present, or even in erythema multiforme, multiple ulcers are present. Coming to the site, certain ulcers develop only in particular anatomical areas. For example, a rodent ulcer will appear most commonly in the ala of the nose. A herpetic ulcer can occur in any part of the mouth. A hapangina can occur in the posterior part of the palate. An angular cheilitis will mostly occur only in the angles or the commissures of the mouth. Coming to the size. In the size, we need to take into consideration both the dimensions of a particular ulcer. That is, the dimensions that you take mediolaterally and the dimensions that you take superior-inferiorly. So the highest mark has to be kept into consideration. A divider can be used, a scale can be used to measure an ulcer. Coming to the shape, most of the ulcers can be round or ovoid shape. Examples can be recurrent aphthous ulcers. Irregular ulcers can be seen, for example, carcinomatous ulcers. Oval ulcers are most commonly tuberculous ulcers. Next, coming to the margins of an ulcer. A margin can be well-defined, ill-defined, well-demarcated, and irregular. An edge of an ulcer can be raised, rolled, everted, irregular, or undermined. Floor of an ulcer. Either the floor can be completely exposed or it can be covered with unhealthy granulation tissue, sometimes healing granulation tissue where more of reddish component can be seen, and vegetation growth may also be seen in certain ulcers. The surrounding mucosa of the ulcer can be erythematous, edematous, pigmented in nature, or it can even have bluish or reddish discoloration. Mostly, we have an erythematous halo which is surrounding the ulcers, which is a characteristic of any ulcer. Coming to the contents of an ulcer, within the ulcer, we can look for pus, blood, or any serous exudates. And discharge of an ulcer. When mild pressure is given over it, we can notice for any pus or serous discharge coming out of it. And the last is attachment to deep structures. It can be present or sometimes it may not be attached to the deep structures. The second part of clinical examination is palpation. Under palpation, the first thing that we need to check is for tenderness, whether the ulcer is painful or whether it is not. Next is the discharge on palpation. When you give mild pressure over the ulcer, whether you are able to find any discharge coming out of it or there is no discharge. Then is the mobility, whether the particular ulcerated area is mobile or it is attached deeply to the underlying structures. Raised margins, whether they are present or they are absent. Whether this ulcer is well demarcated from the normal areas or the surrounding areas, and if the surrounding area appears edematous and erythematous in nature. And what about the induration of the base of the ulcer? If there is induration, it could possibly be a carcinomatous ulcer. Last is the diagnosis of an ulcer. Basic classification of ulcer can be traumatic ulcer, inflammatory ulcers or infectious ulcers, mucocutaneous disease which can cause ulcers, blood-related dyscrasias which can cause ulcers, nutritional deficiency related ulcers, and allergic ulcer. We need to correlate the history and the clinical findings. The ulcer has to be grouped into any one of this particular classification, and after applying the knowledge of clinical examination, the exact diagnosis of an ulcer is perfectly documented. These are some examples of ulcer. We can see the herpangina, which is occurring in the posterior part of the palate. The rodent ulcer, we can see in the aloe of the nose of this patient. We can see a herpetic ulcer, where acute phase of herpes can be seen. We can see a carcinomatous ulcer here, right in the base of the tongue. We can see angular cheilitis in the commissures of the lips of the patient, and we can see a perfect recurrent aphthous ulcer. This is a tuberculous ulcer, and this is again an example of a recurrent aphthous stomatitis. These are some questions for you to ponder. Thank you.